Sir, can we start? Hello?
Yeah. We can start.
Huh. Okay. So, good afternoon, everybody. This is Dr. Bhavna Gadvi. I'm principal at Ahmedabad Institute of Medical Sciences, Ahmedabad, and I am presently a coordinator for State of Gujarat for Indian Association of Physiotherapists Women's Cell. So, on behalf of IAP Women's Cell Gujarat and IAP Gujarat branch, we welcome our honorable speaker for the webinar today. Welcome Dr. Loganathan sir. He is a pediatric and adult neurophysical therapist who is practicing presently in Mumbai. He is a certified NDT and SI from USA, practitioner as well as teacher from USA, and he is having his neurophysiotherapy clinic in Mumbai called Physical Therapist and Consultant Children Therapy Center at Mumbai, and is a director also in Therapy India, Mumbai. Sir is very well known for his integrated approach for the neurophysical therapist, mainly in the pediatrics zone. So I'm definitely sure that sir would give insight to all the physiotherapists who are practicing into pediatric and adult neurophysiotherapy, as well as we are very hopeful that we all would learn something new which is recently practiced in metro city like Mumbai, so that all the participants here would be beneficiary with this webinar. I really thank the president of IAP India, Dr. Sanjeev Jha sir, the head of the IAP Women's Cell and treasurer of IAP National Head, Dr. Ruchi Vasne ma'am, the zonal head, Dr. Pooja Kamble, and Dr. Dhara Sharma, president of Indian Association of Physiotherapists Gujarat branch. With the support of all technical team and the academic team, we are able to organize this webinar today. We would like to thank Dr. Loganathan sir to share your valuable time and knowledge to the participants. Sir, over to you.
Can you hear me?
Yes, sir.
Yeah, thank you for your kind introduction. And thank you for IAP Gujarat Women's Wing for inviting me and having me for this webinar. I'm not a pro in webinar. This is my first experience. So please, everyone, kindly bear with me if there is some shortcomings. Also, I'm not an academician, so I won't be that, professional in terms of presenting. But I'm a clinician. I would like to share my experience, but I have tried to make my presentation as much as academic possible so that it's easy in a webinar format. Okay. So I know sensory integration is a topic for physiotherapists. It is kind of most of the, especially at the students level, it's a new topic. But I will try to make sure that I explain it in very simple and I keep it very basic so that you all understand. Okay. Anybody who doesn't follow in the process, they can stop me if it is very urgent. But if you have a question that you can hold on, then you can ask me at the end. Okay. So can you see my screen?
No, sir.
You cannot see.
No, sir.
Now can you see?
Yes.
Okay. Okay. So SI is a very broad and a very big topic to explain in 1.5 hours time. But I will just make sure that you all have a clear understanding of what is SI and how SI should be used by PTs in their day-to-day practice. Okay. So what is SI? This is how Dr. Jean Harris. Jean Harris is a occupational therapist. She was a special ed teacher. She was a psychologist. She had many roles, but primarily she was an occupational therapist. She's the one who developed this concept in 1960s. So this is what she describes SI as. SI is nothing but a process in the brain. What do I mean by a process in the brain? So if I ask everybody to look around your table or wherever you're sitting, and then if you pick up an object, everybody pick up an object, and then suppose I am picking up this object, which is mobile in front of me, and I know this is mobile. My cognitive ability is telling me this is mobile, but for me to understand, for me to come to a cognitive understanding of this is a mobile, I need to go through a certain process in my brain, and that process is what is nothing but is SI. Okay, so that process doesn't happen at a very conscious level. It happens at a very subconscious level. So SI therapy is not cognitive. That's what it means. It should happen at a much subconscious level. If something to do with cognitive, then it is not SI. I cannot go and treat the child by telling the child what to do. If I go and direct the child saying that you have to do this, you should not do this, step 1 is this, step 2 this, is just if I follow a pattern and if I give an instruction to the child, then that's a cognitive process. Then that's not SI. So SI is a process in the brain, but that process happens at a very subconscious level. Okay. And also, Jean Harris defines SI as a framework for interpreting child's behavior. Okay. So how do I know that? If you see a child and then you see a child, one type of child goes and sits in a corner of the room and plays alone. That's the behavior you see. And you see another child who doesn't sit in one place, constantly running around, and then doesn't stay in one place. That's another type of behavior you see. So this understanding of these two behaviors from a sensory integrative framework is what Jean Harris created. So she's literally telling us that those two behaviors has a sensory base in it. I sit in one place and constantly play in that place because of my certain sensory preferences. I don't stay in the place, but I constantly move around in my environment. That's also because of my certain sensory preferences. So that understanding of children's behavior, and she put it in a framework of model of understanding, that comes from SI. So that's what Jean Harris is doing. So it's a process that's happening at a subconscious level, and also it's a framework of understanding what the child does. Okay. So I told you all, SI is a framework of reference. So what this framework of reference has in it? It has theory, obviously. It has a lot of theory. Theory comes from many sciences. Theory comes from neuroscience. Theory comes from psychology. Theory comes from child development. Theory comes from, positive support practices. Theory comes from
Hello. Hello.
Yeah,
Can you hear me?
Yes, sir.
Somebody muted me. Can you hear me?
Yes, sir.
Yeah. Okay. So I was just telling this framework of reference comes from a set of theories. That theories includes theories that comes from motor learning theories, that comes from neuroscience, that comes from child development, that comes from psychology, that comes from neuropsychology and all sorts of things. Okay, this frame of reference also has evaluation methods. Okay. When I say SI as a frame of reference, it has theory, it has evaluation method, and it has an intervention approach. So how this theory evolves from the time Jean Harris formulated this approach is theory led to evaluation methods, And those evaluation methods led to intervention strategies. As they started doing more intervention strategies, they formed new theories. So it's like a cyclical process. Theory, evaluation method, intervention approach, all leading to one another. So today what I do in therapy will become tomorrow's theory of SI. And some of the newer things that comes from neuroscience will contribute to my future therapy practices, future therapy interventions. And that's how this theory is being evolved from 1960s to 2020s. Okay, so like I said earlier, this frame of reference is developed by Dr. Jean Harris. In simple terms, how do I define SI? SI is a very misnomer word and which is commonly used in pediatric practices across therapists, PT, OT, SLP, even remedial teachers to, everybody uses the word sensory integration. But if you really go and ask them what is the real meaning of SI, I think only few people who are well qualified really understands what SI means. But Jean Harris, for the common use for the public to explain to the general public, how do you explain SI? In simple terms, you can explain that it's just nothing but organization of sensation for use. Okay, I use all my sensory systems and I organize myself so that I can effectively participate in the environment. For example, right now I am sitting in front of a computer where I don't see anyone's face, but I know for sure there are 300 odd people sitting in front of a computer and then looking at me. Okay, it's a daunting task. Okay, in order for me to do this in a very sanity way, I need to organize all my sensory information so that I can be self-organized, self-regulated. I can present this material. If I do not have proper sensory systems that is integrating well enough, I will not have the proper mechanisms to sit in front of the computer, knowing well that there are 300 odd people watching it and won't be able to deliver this message. To do this, I need sensory integration. Take for example, you people are sitting in front of the computer. I know you are not seen on the screen. You can be as much luxurious as possible. You can sit down, lie down, walk around, stand, whatever you want to do. But you are doing all that so that you are integrating the sensory information that you are getting, so you can pay attention and focus on the subject that you are listening to. Even you people are doing some kind of sensory integration within yourselves at a much subconscious level to attend to this lecture for 1.5 hours. So both of us are integrating our sensory system in a different way, but the end result is both of us need to focus on this. Okay, so in simple terms, we need sensory integration so that we can use our sensations, okay, so that we can effectively participate in the environment. Here, I think I have explained it in a very simple terms. As I go on, as I get more opportunities, I will bring about more clarity in this. Okay, so then my next question is, if you understood what is SI definition, so why do you need SI? In what way it contributes to me? Okay, so sensory integration contributes to our daily life, day in and out. Even for you to sleep, you have to integrate all the sensory information. Okay, even for you to eat, you have to integrate the sensory informations. Even you have to walk, integrate, sit, walk. I do nothing in my home. Still, I have to integrate certain sensory informations. Otherwise, I cannot function effectively. I cannot be at peace. I cannot be having better self-regulation. Okay, so this is how Jean Harris says sensory experiences must be organized and interpreted in order to participate in occupations. Occupations can be anything. I can be a computer engineer. I can be a therapist. I can be a movie actor. I can be a sports person. I can be cleaning. I can be the person who is cleaning the streets. Whoever I can be, but I need to integrate all the sensory informations that I am surrounded with in my environment as well as within my body in order for me to participate in my occupations more meaningfully. Okay, so today we are all therapists. Okay, we are all physiotherapists for a reason, because of our early childhood sensory experiences. Okay, so you can argue I was very poor in mathematics. That's why I couldn't take engineering. I was good in science, so I entered the science field. So there is a reason why you were not good in mathematics, why you were good in science. Okay, so even this is related to our early childhood sensory experiences. So I am good in certain subjects and I'm bad in certain subjects. It's not that I lack the ability to learn. It's my early foundational skills of my sensory experiences right from utero and the early childhood of my exposure to the environment and the sensory experiences is contributing to the skills that I possess in order to learn certain subjects, certain languages, and certain skills. If we understand this, we can change our lives. We can change a child's life. You go into the school environment and then you see a child good in something and not good in something, and there is a reason. And that reason primarily is a sensory reason. If you go and assess them and then see, there will be some sensory system that is contributing to that child's inability to learn that particular subject or language, whatever you can call it as. Okay. For example, you can think like, out of 300 people sitting in front of the computer, not everybody plays sports, right? Why? If you ask ourselves why, you can say, oh no, I'm not interested. Why you are not interested? No, I don't possess the necessary skill. Why you don't possess the necessary skill? So if you start to answer all those things, it will come to the bottom, since your early childhood sensory experiences will be one of the key aspects. Of course, genetics plays a role. Of course, your organization of the central nervous system plays a role. But for that central nervous system to enrich itself, it needs sensory experiences. Okay? So that's what she says. So for us today we are therapists for a reason, because of our early childhood. Somebody else is a cricketer like Virat Kohli or Sachin Tendulkar because of his her early childhood sensory experiences. Okay? So that's what it says. Sensory experiences contributes to skill development. Okay, so some people are good in mathematics. Again, I go back to the same example because as a childhood I was very poor in mathematics. Now I know why I was poor in mathematics. Because if I know my sensory systems, my vestibular sensory system is not that great. It's not integrating well enough. And my vestibular sensory system and the learning of academic skill of mathematics is directly correlated. So I won't get into this, but that's how it goes. Okay. So regulation of emotional and arousal states. What does that mean? Regulation of emotional and arousal states. My ability to handle a situation, okay, that requires a lot of self-regulation. Okay. So if I am able to do things that is highly demanding, stressful, challenging, I'm able to cope that well, that in a way says that my ability to regulate my emotional and my arousal states pretty well. Not everybody can do that. It's not that they don't lack it, because of their early childhood sensory experiences, they have that inabilitiness that puts their emotional and arousal states haywire and they are not able to regulate. And that's also is contributed by how well they integrate the sensory information that is present within their body as well as that comes from the environment. Organization of behavior in space and time. What does that mean, organization of behavior in space and time? Meaning, again, I'll take for this example now. So I have to make sure I have all the materials present here. I know, am I going to use anything else? I have to keep it ready. I need to drink water, so I have to keep a cup of water. This is what is organization of my behavior in space and time. I know for the next 1.5 hours, I cannot get out of this screen. So that whatever I need in my next 1.5 hours, I have to make sure that is kept around me so that I don't leave the screen. That's called organization of behavior. Okay. And second thing, I don't sit here and then I don't sit like this. And then I do like this over my head. If I do that and I become so friendly and casual in front of you, for this environment, that's not a good organization of behavior. Right? You all people sitting in front of the computer whom I am not able to see, you can lie down, you can do whatever you want to. You just have to listen or see. So for you, if I call it that is not a good organization of behavior, it's for me to do all these things, I need to integrate my sensory systems very well. These are the daily things that we do, but we don't generally pay attention to it. But that's why it's very critical. For everything that we do in life, we are constantly and consistently integrating the sensory information that it has. Okay, so sensory integration influences the occupational choices and formation of our own identity. That's what I said. Today you are a therapist. It's because of your early childhood sensory experiences. That is creating your identity. If somebody is a teacher today, it's because of their early childhood sensory experiences that they are teacher today. Okay. So you can ask me. So if I had a different type of sensory experiences in my childhood experience, would I have been a different a person than being a therapist? Of course, you must have been. You don't know until you do it. Okay. So the bottom line is our early childhood sensory experiences determine the person who you are today, the professional who you are today, and the skills that you possess. It's all the foundation stone is laid in your early childhood experiences. Okay, I think if this is clear, you got it everything. Okay. Okay. So I kept saying sensory integration is a process in the brain. So since it's a process in the brain, can we observe that process? I don't think so. Okay. But what we can observe is we can observe behaviors. Okay. So now you are all seeing me. You're all seeing me how I'm sitting. Am I sitting still like this and then talk with you for the next 1.5 hours? No, I'm constantly moving. Why? There is the reason. You have to think why. Okay. So we can only observe behaviors. We can only observe child's behavior. What does the child do? Does the child sit in one place? Does the child run around? Does the child play with its peers? The child does things creatively or goes to things that are very monotonous, doesn't need a lot of problem solving. These are the things that you have to keep observing. Okay. So once you observe the behavior, we tend to hypothesize that behavior and then relate with our theories from neuroscience, child development, psychology. And you relate those behavior with that and you come up with a hypothesis of what can be happening in the child's brain. And you relate to each sensory systems. I know this will be a little kind of abstract how you do it. As you understand each functions of each sensory system, you will get to know how we hypothesize and how we relate the child's behavior to the sensory system and whether integration is happening or not. Okay. So she's Dr. Jean Harris. She was an occupational therapist. She was an educator. She was a researcher. She developed this theory. She developed a lot of tests. So that's called sensory integration and praxis test. Okay, and she developed a lot of therapy equipment. So some of the things that we use in clinics today, the primary model came from what Dr. Jean Harris used in her early 60s and 70s. Okay, this is just for you to know that she is the one who developed this approach. She's just a pioneer in field of occupational. Okay, so what made her a pioneer in this? Okay, this is what is Jean Harris' legacy. She proposed that there is a link between deficits in the bodily sensation, okay, the information that comes from bodily senses, and she related that to the kind of behavior and the learning that we did in day-to-day living. Okay, so she proposed that link. She said there is something impairment. She didn't say what it is, but some kind of impairment that is there in the bodily sensory system. Okay, and that is contributing to the way that we learn things, we behave in life. And this is happening with apparent no damages in the brain. If you take an MRI scan or CT scan of the brain and then see there is no obvious damage in the brain, but still she correlated that there is some deficits in the way our bodily sensory systems interacted among themselves so that we behave in a certain way. Okay, so once she established that relation, she did a lot of research, conducted a lot of studies, she conducted a lot of research to establish this fact. That's when the evolution of sensory integration. Okay, this is just a little bit of history about how SI came about. Okay. So after doing all that analysis, this is what she came up with to understand what it is in 1979. So this is the model that Dr. Jean Harris came up with. Today there are a lot of other models that are available, but this model is even relevant today. It's highly relevant today. Just because it was developed in 1979 doesn't mean that this model doesn't have any relevance. This is relevant. Okay. Okay. So if you look into it, right side of your screen and left side of the screen. Left side of the screen has three basic sensory systems: vestibular, tactile, proprioception. I know you all must be knowing what is vestibular, what is tactile, what is proprioception. Okay, in short, I will explain. Vestibular sensory system is there inside our ears, somewhere inner ear, okay, middle ear, it's there inside. Okay, what does that do? It has many functions, I'll explain. Proprioception, you all know what is proprioception, okay? You get proprioception from muscles and joints and muscle tendinous junctions. From there are lots of proprioceptive receptors, okay? When you close your eyes and then move your joint, that is kinesthetic sense, part of proprioception. Okay, so you're able to do that. It's all through these sensory systems. Okay, tactile system, wherever skin is, you have tactile system. Tactile system is the largest sensory system. Okay, largest sensory system because it is there from top to the toes. Okay, it's there everywhere. Okay, so why did Jean Harris focused on these three sensory systems? There is a reason. Because these three sensory systems are the primary sensory systems. When I say primary, why do I say primary? Because it is present right from utero. Even before you were born, these sensory systems starts to develop. I'm not saying it is mature. I'm saying it starts to develop. Okay, you develop vision and auditory. Okay, much later on in your childhood. Okay, you get to adult vision by the month of 6 months after birth. Until that time, your vision is hazy. You don't learn from the environment through vision. You learn about your body and about the environment through these three sensory systems. That is vestibular, tactile, proprioception. So the learning of the child is not happening right after birth. It's happening right from utero. Right from the day the child is conceived, the child starts to sense informations, okay, about its own body by proprioception, vestibular, and tactile sensory system. Okay, so that's why these three sensory systems are called as primary sensory system, because these three sensory systems provide information about your own body, whereas my vision, my auditory gives information about my environment. Okay, I hear something that's about my environment. I hear a loud sound. I know there is some danger. Okay, I see beautiful green leaves. Okay, so that's there are lots of trees there. So that information is telling me about the environment. Okay, so now I am sitting, but I'm not falling. How do I know this? Because my proprioceptive sensor system and my vestibular sensor system is telling me, my body, that I'm sitting, staying upright against gravity without falling, having balance. So that information about me comes from these. Is this clear? So that's why it's primary. Because it's primary, because without, if you don't understand about your own body, you cannot learn anything from the environment. Okay? For example, you can, if possible, people can take a piece of paper, okay? And take a piece of paper and make it a roll like this, put it back on your shirt. Okay? And then you sit with it for next 1 hour. Okay? If this paper that I have put, if it is constantly in your mind, that means your ability to process sensory information is impaired somewhere. Okay? That means you have some kind of sensory integrative dysfunction, sensory processing difficulty. But for some people, it doesn't bother at all, but still they are able to pick up, pay attention, focus for the next 1 hour. So that means their ability to process sensory information is much more. Okay? So when you have problem, either in vestibular, proprioception, or tactile sensory system, this is one example I just gave you. So I will not be a child who can sit in one place without moving. Even now I move, but I move subtly. But as a child, hello, can you hear me?
Yes, sir.
Okay. As a child, if I have, can you see the screen?
No, sir.
Okay. Sorry about that. Can you see?
No, not yet.
You can't see the screen?
No, sir. We can see you. Yes, now it is visible, sir.
Okay. So, yeah, when you have a problem related to process the sensory information, you cannot, your attention will be on your own body, not in the environment. You will be able to see well, you will be able to hear well, but your brain will not have the ability to process all those information when you have some impairment in your bodily sensory system. So these three primary sensory system, vestibular, tactile, and proprioception, are your bodily sensory system that gives more and more information about your body. Okay? Okay. So if you see the screen, you have vestibular and you have proprioception, and then there is one line that is connecting both vestibular and proprioception. And then after that, it says eye movements, posture, balance, muscle tone, gravitational security. Is everybody able to see that? If you are able to see that, what does that imply is, if I am able to integrate my vestibular information, the sensory information that comes from my vestibular system, as well as the sensory information that comes from my proprioceptive sensory information, get these functions. Okay, when I read a book, I need to have a good saccadic eye movements. Okay, that is possible only if there is an integration of vestibular and proprioceptive sensory system. Okay, second one, posture. Whether you are sitting, standing, running, whatever you do in life, that you are able to maintain that posture without losing balance is because of your ability to integrate vestibular and proprioceptive sensory system. Okay. Third thing, balance. I told you balance. Fourth thing, muscle tone. Okay. So for us to have muscle tone, if I am able to integrate vestibular and proprioceptive sensory system, then I will have a better extensor tone of my body. If I'm able to integrate vestibular and tactile, proprioception and tactile sensory system, then I will have a better flexor tone of the body. Okay. So as a PT, we yeah. Sorry. Okay. As a PT, I know we are all focusing more on posture, muscle tone, muscle strength. So when we work with children, when we see children with low tone, when we see children who have postural control issues, you will also have to not only think about muscle strength, but you also have to think about why that muscle strength is not there, why that muscle tone is not developing. Is there a sensory reason behind that? Then you go and assess their vestibular system and you go and see how well their proprioceptive integration is, vestibular proprioceptive integrations. If you find that there is deficit in there, instead of just strengthening the muscles, you need to work on integration of the vestibular proprioceptive sensory system first before you go on to strengthen the muscle. Does that make sense? I hope that will make some sense. Why PTs need to understand sensory integration. Okay, and gravitational security. Okay, so many a times we do many a times we see a lot of kids who have fear of height, fear of moving in space. Okay, how many of us have that? I have fear of height, I have fear of moving in space, and that's why I have poor mathematical skills. Okay, so this is all connected with each other directly. Okay, so if I have all those things, when you see a child, a family comes in and says, okay, so when you lack fear of going in height, you have to immediately think it's something related to vestibular proprioceptive processing problem. Okay, so these are the 5 things that you should remember even in your dreams. Okay, the main functions of integration of vestibular system as well as proprioceptive sensory system is this: eye movements, posture, balance, muscle tones, gravitational security. If you see a child have problem in any of these areas, okay, you know exactly where the root problem is. That is disintegration of vestibular proprioception. Like both the sensory system doesn't integrate well enough, clear cut. Okay, without doing any assessment, you can say, I'm not saying don't do any assessment, but you can come to a conclusion there can be a problem that is related to vestibular and proprioceptive sensory system. Okay, you come down, you see after tactile, you have sucking, eating, bonding, and tactile comfort. These are the functions of the tactile system. Okay, so if a child have problem related to sucking and eating problem, feeding problem, you hear a lot of these complaints when you work in pediatrics. Child will say, the family will say, my child is not able to take solid foods. He can only take liquid food. Okay, even if he takes liquid food, he doesn't have the ability to swallow. He just rules it out. So you have many issues, then articulation issues, speech. A lot of things, the base problem is the tactile system. Okay, so you have to, when you see this problem that is coming in your clinic, first thing you have to think as a therapist who uses sensory integration in your frame of reference of practice, you have to relate to these sensory systems as a base for those problems. Okay, so if you are clear with this, you come to the middle segment. There is a big line, that is, if I can integrate vestibular, proprioception, tactile, all 3 sensory system effectively well, then I develop of better body perception. Okay, body perception, there are 3 things in body perception. One is body image, body awareness, body image, and body schema. Body awareness is nothing but I have eyes, I have 2 eyes, I have 1 nose, I have 2 ears, is body awareness. Body image is nothing but my hands are closer to my mouth, whereas my legs are far away from my mouth. That is body image. Body scheme is nothing but how I use this body in relation to my environment. Meaning, I walk into a room and I see a chair and I know for sure I can fit into the chair. That's body scheme. Or I walk out of the door and I know it's short. So while walking out, I bend myself to walk out. That's body scheme. Some children or even for some adults lack this quality. So when they don't have it, or when you don't see these things in your clinic or in your assessments, then you can start to think there is some problem related to integration of vestibular, proprioceptive, and tactile sensory. Second thing, coordination of 2 sides of the body. You will hear this from all families when you work in pediatrics. He cannot button his shirts. He cannot unbutton. He cannot put on his shirt. He cannot don off his shirt. Okay? These activities, he cannot do cycling. He cannot do writing. He cannot do some hand activity. These requires coordination between 2 sides of the body. That is, if you see problem there, it's usually what happens is therapists go to that task and keep working on that task. Instead of doing that, you have to think, okay, you see a child who has this problem, so my sensory systems, when it is integrating well, these are the functions I get. I think this child has problem in this area. That shows me the child is not integrating well enough. So let me go and work on that integration first. That makes sense to you all. Okay. So then the third one is motor planning. What is motor planning? Again, whatever I do in terms of maneuvering my space, maneuvering in my environment, my movement in my environment is motor planning. Okay. How I go to my office today from my house is motor planning. Do I take this street? Do I take left, right? Or do I take a short? That is also motor planning. Or how I get up from this chair You go to the other room, how do I move in space? That is also motor planning. Third thing, while playing, everybody knows playing cricket. When I'm playing cricket, how I hit that ball, should I have to go front foot or back foot? That's also motor planning. Okay, how do I write? That is also motor planning. So any kid who has problem relating, doing these kind of skills or ideal skills is related to motor planning issues. And when you see a motor planning issues, you very well know the child has difficulty integrating vestibular proprioception and tactile sensory. Okay, so then come down, you see activity level, attention span, emotional stability. This is very key. And these three are written in conjunction with the tactile system. You see that? This is in conjunction with the tactile system. I'm just pointing with my arrow, mouse arrow. Okay? So what it says is my ability to sit in front of the system. Now you're all sitting and you're listening to me for half an hour. Your ability to sit and pay attention. If anybody has trouble, okay, it's not the lecture is boring, okay, but your ability to integrate sensory information is limited. See how well I'm throwing the blame onto you people. Okay, so basically, I'm just kidding. Basically, for our ability to pay attention and stay there, stay put for long enough, I need to integrate my sensory system effectively. If I cannot, okay, if I cannot integrate my sensory information easily, then my ability to pay attention, have a sustained attention is impaired. Okay, so you have to keep this in mind. So that comes with integration of the tactile sensory system along with vestibular and proprioception. So this tabular column is very relevant. So that's why I'm spending more time here so that if you know this, you somehow can. I'm not saying you'll be knowing everything, but at least you have something to start with in your practice. If this needs to be there with you all in your head all the time. So you have something to assess and something to treat to begin with. Okay. Okay. So if I'm able to do this, then the kid develops the ability to do these functions. That is eye-hand coordination, visual perception. These are all higher level functions and doing any meaningful, purposeful activity. So these three can happen only if these two can happen in a child. If these two can't happen, the problem lies here, the integration of vestibular, proprioceptive, tactile sensory system. The problem in pediatric practice is you might see children here sometime. Okay? The parent will come and say, or the teacher will come and say, he doesn't do these activities, eye-hand coordination, visual perceptual activity, or they will say he doesn't sit in place and do a meaningful activity. Doesn't sit in a place for 5 minutes. Okay, you will see kids here. Rarely you will see kids here, okay, but mostly here, okay. And then sometimes you will see problems here, okay. If you have all these things, the end product of this is the child will have better ability to concentrate, ability to self-organize, child will develop better self-esteem, self-control, self-confidence, better academic learning ability, my capacity to learn, do a lot of abstract thinking, and my specialization of each side of the body. So all these things will happen. The base is integration of vestibular, proprioception, tactile. If this is not happening in your body, you cannot develop these skills. In clinical practice, you might see problems here, you might see problems here. Okay? The best way to deal is most of the time, the therapist works here or here. Okay? They will do an activity, a task that has better eye-hand coordination or visual perceptual skills, or they might engage them in a meaningful way. Some meaningful activity. I'm not saying don't engage them in a meaningful way. You have to engage them in a meaningful way, but at this level, you have to design activity in a creative way such that you address the integration of the vestibular, proprioception, tactile sensory system. Not work on eye-hand coordination, not work on body perception, not working on coordination of two sides of the body. Those things has to develop automatically. Okay, these things has to develop automatically. But doing so, what we do is we use a lot of cognition in our therapy practices. I said in the beginning, SI is a subconscious process. It's not a cognitive process. I know many therapists who in an SI setup have everything, but they use a lot of cognition because they give a lot of directions. A lot of, you do this, you do this, you do this. That is a cognitive process. Okay, that can be called as a cognitive therapy, but not an SI therapy. If you use cognition, that's a different approach. That's not SI. Okay, if it is pure SI therapy, that means you are using primarily these three sensory systems, not even vision, not even auditory sensory system. You're using tactile, proprioception, vestibular, and integrating all these three things. I'm not saying you shouldn't do vision. You can do vision, you can do auditory, but that's not your focus. Your focus is how do I create the opportunity in the child and in the environment that the child can use these three sensory systems effectively, that they can integrate. So that I develop body perception, coordination of two sides of the body, better motor planning, better activity level, more attention level, more self-confidence, self-esteem, blah, 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 blah. All these things will come automatically if they are able to do this. Okay? I think you should be very clear with this. This is kind of like a foundation basics. Okay? This is very basic, okay, but it's a very foundational. If you know this, you know something to start with SI. Okay, and going forward, okay, if you're not able to get this chart is easily available on Google. Okay, you just type Gene Harris SI model, you will get it. Okay, so this is another model which I'm not going in detail. I'm not going to describe in detail because this will take a lot of time. But this is another model. This is an Bundy-Murray model which came in 2002. Okay. Literally, it's talking the same thing, but there is clinical grouping of dysfunctions. Okay, there's a clinical grouping of dysfunctions. This is the one which we commonly use. Okay, so this was done by Miller in 2007. So this I will explain in detail. So when a child who is having SI dysfunction, okay, if a child is having SI dysfunction, we call them as a SPD, sensory processing disorder. Okay, so you can ask me, okay, you said SI is a process that happens at a subconscious level. How do we know when we look at the child, that child is having an SI problem? Okay. So in order to explain this, I'm going to step back a bit and I'm going to give you the current situation as an example, and I'm going to do this. Generally, typically, suppose if we are present wherever we are present, for example, I am taking me as an example, I'm going to give you. I'm in my house, I'm sitting in front of the computer. I have a window here, I can hear a lot of sound here, I can hear my fan going, I can hear that sound, there is light, there is so many things in front of me. I can see all these things. There are so many sensory input. There is vision, there is auditory. I can feel this shirt, that's tactile, okay? It's hot here, I can feel the temperature, again tactile, okay? I'm sitting upright, there is vestibular input. I'm moving my hand, there is proprioceptive input. So I'm getting all the sensory system that is activated in me, okay? I can feel it. Every sensory information comes into my brain. My brain gets all the sensory input. That's the first process. Sensory input is the first process. Second process is sensory registration. So all the sensory information that I gather from my environment is getting registered in my brain. Okay? My question to you all is, do I pay attention to all the information? Wherever you're all sitting, are you all paying attention to all the information that is surrounding you? No. You might be paying attention to 2 or more, but not everything. Okay? So what do you do there? There's a third process called sensory filtering. You are filtering out. I'm filtering out sound that's coming from outside, that's coming from my fan, everything I'm filtering out. Okay? I have that ability to filter out. Okay? Some children lack that ability. For example, forget about children, even adults lack that ability. For example, how many of you can pick up a mobile phone in a crowded bus or train and speak at a normal pace? I have seen people who, I can take again example as me. I don't pick up calls when I'm traveling in train because I know for sure I cannot hear the person. Okay, effectively. It's not that I don't hear it. I cannot be functioning effectively. So I know it, I don't pick it. Some people do pick up the phone. Okay, but how do they speak? They speak very loudly. You must have seen all these things in your day-to-day life. You can know about their family life. You can tell their whole story by the way they speak in the on the phone. Some people talk, they pick up the phone, talk, but very mild. You can't even hear what they talk. And they're very calm, quiet. They're not hyper, they're not aroused, they're not like going like nothing. Very calm, quiet. Those are the people who has the highest filtering ability. Some of our children, you would have seen in some people, if you have the practical experience, children come and close their ears. Children come and close their eyes. Or they come into an environment and then suddenly they become hyper. They become hyperactive and start to do some kind of temper tantrum, some kind of behavior, all of a sudden. Okay? You have to think maybe the child's filtering ability is impaired. That's why something in the environment is creating that kind of a behavior. So that's why when you treat the child, environmental modification and environment also should be part of your assessment and treatment. You're not only just treating the child or the family, you're treating your own environment. You're using your own environment to look for instances that is present that is causing this behavior. So when I say sensory processing disorder, this sensory filtration ability also comes into it. I have sensory input, I have sensory registration, I have sensory filtration. Then comes, once I filter out unwanted things, then comes sensory processing. So that's a process. Okay, so now I am looking into the my computer and I'm looking at all the slides. Okay, what is there in the slide and how I say this? Okay, it's there. Okay, let me say it like this. So how I'm processing, that's processing. You're all hearing me. You're looking at the screen, and you must be processing this information in a different way based on your experiences. Okay, so that process comes if you have the better filtering ability. If I don't have better filtering ability, you remember I asked you to put this paper in back. Okay, that's your lack of filtering ability. Okay, or modulation problem. So what you will be doing is you will be focusing on this instead of what you are hearing me. So that's kind of a tricky. So remember this process. Once filtering is done, you have processing. Once processing is done, then you develop the discriminatory ability. Okay, so then discrimination ability is nothing but I can say, is this information okay or not okay? Is this okay? I mean, is this good or not good? Or is this bad or harmful? It can be anything. Okay, so I go into this environment. I know there's a sudden flash of light that comes in, and then after some point of time, after processing it, I know this light is not harmful to me. So I can ignore. And if I know that light is harmful to me, I cannot ignore. I need to move away from this place. So those kind of reactive reactions that you do based on your discriminatory ability. Okay? And fourth thing, and modulation. What is modulation? Modulation is another process. Okay, you are listening to me, and then all of a sudden I go like this. I started talking very slow. And you don't hear, in the end, you don't hear me. What do you do after some point of time? You ask me to be louder. Okay, or you go and increase the volume in your computer. Okay, those are all better modulation behavior. That means you have a better modulating behavior. What if you don't hear me and then what do? You shut off this program and then you go away. That is not better modulation behavior. Better modulation behavior is either you come forward and then, oh, what is he saying? Or you can say, can you be louder? Or you can increase the volume of your computer. That is modulation. Okay, when children cannot modulate, cannot do filtration ability, okay, cannot discriminate between good and bad, harmful and not harmful, then they are categorized in one group that is called sensory processing disorder. Okay? When your children cannot do these functions efficiently, and that is leading them to absenteeism, showing unnecessary behaviors, poor academic learning, poor self-control, low self-esteem, all those things that we discussed earlier will show up in them because they have sensory processing disorder. Okay. You would also, some places you will also hear some people calling it a sensory integration dysfunction. That's and sensory processing disorder, both are same terminologies. Different people use different terminologies. Okay. Okay. So coming back to SPD, again SPD is divided into three, which is there in your screen. That is sensory modulation disorder, okay, sensory based motor disorder, and sensory discriminatory disorder. Okay. Clinically, to identify this part, sensory discriminatory disorder, is very, very difficult. Unless and until you do a sensory integration praxis analysis test, you cannot say it clinically. Okay. So I'm not going to talk about that at all. But I'm going to talk about these two things. One is sensory modulation disorder, other is sensory based motor disorder. So what is sensory modulation disorder? Okay. It has two main things. One is sensory over responsivity. Okay. What you call it, you see it, or you have heard from people saying it very casually in the name of hyperactivity. He is a hyperactive child. You must have heard this word most often. Okay. So that is nothing but sensory over responsivity. Okay. What is sensory under responsivity? Sensory under responsivity is a very lethargic child who doesn't do anything at all. He's very quiet. He doesn't participate. He doesn't play with his peers. His muscle tone is very low. He doesn't move at all. He sits in one place for a long time. Okay. He's always sleepy. Okay. He's always floppy. He's always sloppy. He's falling everywhere. Okay. He's clumsy. These are the words you would have heard from people. So those are sensory under responsivity. There are two categories. Sensory over responsivity is nothing but hyperactivity, and sensory under responsivity is nothing but hypoactivity, less activity. Okay. Okay. So we know now gene array sensory integration involves three sensory systems. One is tactile, vestibular, proprioception. Okay. Now, when I say sensory modulation disorder, the sensory modulation disorder can come in all three sensory systems: tactile, vestibular, proprioception. Okay. When it comes in tactile, so now I'm going to talk only about tactile sensory system. Okay. When I'm in tactile, when I'm talking about tactile sensory system, if I am sensory over responsive to tactile sensory system, meaning this is a tactile input, this paper is a tactile input, but if I get this tactile input here or here or here, I don't like it because this kind of stimuli is too noxious for me. Okay, I am over responsive to this tactile input. Okay, some of the adults are tactily over responsive. We have seen some kids are too. Those kids don't like to put water on their head. They don't like haircuts. They don't like nail cutting. They don't like to brush their teeth. They don't like soap on their face. They don't like anybody touching their face. These are the kids who are tactile sensory over responsivity. Clinically, we call them as tactile defensiveness. I know this is little stretching too much, okay? But just remember, these are all tactile defensive kids. If I am over responsive to tactile input, I am clinically called as tactile defensive. Okay. What if I'm under responsive to tactile input? Meaning, you give me anything. For example, we have the experience of going in the bus, right? Okay, going in the bus, train, and especially when we do night journey, and especially people who sit on the middle seat of the bus. Okay, you do a night journey. What happens in the middle of the night? One person comes and sleep on us, this side. Other person comes and leans against us. Okay, some people cannot tolerate this. Okay, that's tactile over responsivity. Some people doesn't mind that. Everybody is like, if somebody leans on you, you don't mind it because you don't even recognize that. Okay, that is tactile under responsivity. Any sensory information that I'm getting, that I I don't react to it, or it doesn't make any meaning to me, or I'm not affected by it, or it doesn't really bother me. That kind of children, okay? These are children you will always see leaning against the surface. When you ask them to sit in a chair, they don't sit tall. They sit like this, like a floppy sitting, like this sitting. And then when you sit in a group, they don't sit quietly. They lean against others. Or people who always look for some place to lean against. Those are all tactile, under-responsive people. You can also relate them to postural control issues. Okay, you can make a distinction, but there is a sensory base to that postural control issue, and that comes from tactile proprioceptive processing ability. So this is the two category for tactile system. Now coming back to vestibular system. When my vestibular system is sensory over-responsive, then it is called gravitational insecurity. Fear of height, fear of fall, fear of moving in space, fear of moving objects. I can't go in a bus sitting on the window seat. I can't travel in a bike who drives very fast. These are all fear of motion sickness. These are all comes from sensory over-responsive to vestibular system. Okay. Sensory under-responsive to vestibular system you have? Yes, you have. But there is no clinical term for it. You just say under-responsive to vestibular input. Same way for tactile, you say under-responsive to tactile system. But when they are over-responsive, you have tactile defensiveness, you have gravitational insecurity. So vestibular under-responsive people, what usually they do is they like a lot of movement. They like to be on the move. There are some people who like to drive fast and they have fun. Those are all vestibular under-responsive. Some people all the time like to sit on the window of a bus and like to watch the movement. Those are all vestibular under-responsive. People like to go on all these giant wheels and roller coaster rides, and they have a lot of fun. Those are the people under-responsive to vestibular input. That's why they have fun. People over-responsive to vestibular input, they don't have fun. They get motion sickness. They do vomiting. They can't take such input because they are over-responsive. But under-responsive people is the people who have the maximum fun going in moments. Okay. How do you see these kids clinically? Yes, the children who come to your clinic who are under-responsive to vestibular doesn't stay in one position. They constantly on the move. You'll also hear from teachers and family complain that he doesn't sit in one place at all. He doesn't like to do things not more than 5 minutes. He wants to move. He always on the run. He climbs. He jumps often. All these things that you will hear from parents. Okay, so those are all the kids who have sensory modulation disorder who come under two categories. One is over-responsive or under-responsive. You treat these children too differently. Okay? Today I'm not going to talk about treatment because I won't have enough time to talk about treatment. But you have to understand this needs to be treated differently. Sometimes, clinically, you don't get a classic case of, okay, this child, sensory modulation, over-responsive to tactile input. No. Okay? We always get this mixture. A child will have sensory modulation over-responsive to tactile input, but under-responsive to vestibular input. Okay, so now you have to, in your assessment, you have to make that distinction of which is primary, which is secondary, or how do you treat it? Okay, or is the child is doing certain things because it is over-responsive or under-responsive? Because over-responsive to tactile child, what is the clinical symptom? It's a tactile defensiveness. Anybody touching them, they don't like. So in order to avoid touch, they will be constantly on the motion. They'll be running around because they know if I stay in one position, somebody else is going to come near me. So they'll be on the move. Would you relate this to tactile over-responsivity, or they like movement because they are under-responsive to vestibular system? Are they moving? That's a tricky thing. Okay, so these are the things that you will gain, or to say, direction of how to understand this child as you practice more. But in clinically, there is no clear-cut case of, okay, this is the child only under-responsive, only over-responsive. There is nothing, always mixed. Okay, you don't get like that. And the second category called sensory-based motor disorder. Okay, so most of us as adults, okay, we might have problem in these areas. Okay, when kids who is above age of 7 years, okay, they must have started out as sensory modulation disorder, but as over a period of time, they enter as they age up, they develop sensory-based motor disorder. That is being categorized into two types. One is called as dyspraxia, okay, praxis disorders, and other is called as postural disorders. Okay, simple. Praxis disorders nothing but if I have tactile modulation, modulation problem in my tactile system, plus I have motor planning problem. Please listen to me carefully. I have tactile modulation problem. Tactile modulation. It can be over or under responsive. It can be anything. Okay. Plus motor planning problem. I come under somatodyspraxia. Okay. I just don't have only modulation problem. I also have motor planning problem. Then I will not be classified under sensory modulation disorder. I will be classified under sensory-based motor disorder. That is somatodyspraxia. If I have vestibular problem, it can be over or under, okay, plus motor planning problem. Then I will be classified as postural disorders. Sensory-based motor problem, postural disorder. Is this clear? So sensory modulation disorder, tactile vestibular, under, over tactile defensiveness, under responsive to tactile, vestibular, over responsive to gravitational insecurity, under responsive to vestibular input. When they have additional motor planning as an issue, then they will be classified as a praxis disorder. If it is tactile, if it is vestibular, then they will be classified as postural disorders. PTs come majorly in this categories. Most of the time, PT interventions and PTs need to use SI primarily to address this issue. Modulation issues, primarily OTs will address. Okay? Okay? You can argue this issue can lead to this. Yes, I will address this, but my focus is this. Okay? If I'm focusing this, then I'm not true to my own domain. Okay? SI is a concept is being used by PT, OT, SLP, all three professionals. Okay? So we have to respect our own domain and then use this concept. You cannot use it everywhere. So when I might do all these things. I know how to do all these things, but my focus and end result is postural disorders. How do I work on that? That's my focus. Okay, I'm not working on. My focus is not sitting here and then changing it forever. My focus is how do I get this postural disorders change so that the child can be functionally better. Okay, so is this clear? So sensory processing disorder, you can all wonder. I said gene iris SI constitutes three sensory systems: tactile, vestibular, proprioception. But I talked here in this SI dysfunction, this is SPD. I talked only about tactile and vestibular. I didn't talk about proprioception. Why? Okay, so why I didn't talk about proprioception is so far, we never have, even through research, we never have anything as such under responsive or over responsive to proprioception. We have in tactile, we have in vestibular. For proprioception, there is nothing called under responsive or over responsive. Okay. Second thing, always tactile system always works in combination with proprioception. Vestibular system also works in combination with proprioception. Tactile system or vestibular system on its own doesn't integrate. It integrates always with this proprioception. So there is a saying among our professionals who use SI as a frame of practice: when in doubt, use proprioception. If you do not know what to do with your kid, you just give proprioception. You'll always be right. Okay? Because proprioception is a moderator sense. It's a moderator sense. It kind of binds everything and it kind of grounds everything. That's the uniqueness of proprioception. Okay, I can go on and talk about proprioception because of proprioception there are a lot of neurochemical changes that happens within our body. Okay, if I go to talk about that, we can't finish on time. Okay, so remember this: when in doubt, is proprioception. But as a proprioception as a major problem, you don't have a separate clinical entity. But does the children have problem? related? Yes, they will always have problem related to proprioception, but that is either in combination with tactile or vestibular. They don't have purely proprioception as a major problem. Okay, either it will go with proprioception, tactile or vestibular. Is this clear? Okay, so as I told you, I'm not going to talk in detail about sensory discrimination disorder because clinically it is very difficult to identify. You have to use a SEPT test to identify the STD, sensory discrimination disorder. So remember this. Okay, I think this also you will get it from when you Google it, Miller's model. You will get this piece of information. So I'm not going to. So I just want to talk about the functions of each sensory system. So I will go to that directly. These are all common things that I told you before. So in gene Ares SI, the emphasis more on tactile, proprioception, vestibular. This I said this earlier at the beginning of my session. Why? Okay. So these are the functions of the tactile system. You have to pay attention to this because this lays the foundation for these things. For my emotional development, for my emotional stability, for my emotional, what do I say, sanity, okay? I need to have a better tactile system. If I do not have this, I don't develop this. And remember, if you are not emotionally stable, you cannot have any kind of learning, okay? You cannot, even if your sensory systems are good enough, okay? Even your physical motoric system is good enough, sensory system is good enough. If you are not emotionally stable, you cannot learn anything. You cannot develop any skill. And then we talked about body scheme. This is one of the elements that is critical in developing body perception. Okay? Body perception is very important to know about you so that you can deal with the environment. Body scheme is one thing, that how you use your body in relation to the environment. Okay? That is developing because of the tactile system. The boundaries of you, your boundaries of your body is skin, and that's given by the tactile system. You know your body ends there. Brain knows our body ends there. That comes from the tactile system. Okay? If I have good tactile system, I develop these skills. Tactile perception. Okay, I hold this pen and I know this is soft, this is hard, this is dangerous, not dangerous, this is hot, cold. That kind of perception, everything comes from tactile system. Okay, the tactile system gives information about this shape, size, qualities, textures. But when you feel this, what you form in the brain is a visual representation of what you feel in tactile perception. So your tactile system is contributing to your visual perception skills in the brain. I think you will get this. Okay. If you close your eyes and feel anything, whatever you take in your hand, you know what the shape, what the size, what the texture, everything. But you form an image in your brain for all these things, and that image is a visual image, not a tactile image. But the tactile system is contributing to that. Okay, and motor planning. Okay, so I said tactile system. Okay, if I have to explain motor planning, how it is connected, then I have to talk about there is something called dorsal column medial lemniscus tract. Okay, which we all would have studied sometime earlier. Okay, so one of the function of that tract is the flexion of the joints. Okay, flexion of our joints. All joints, when you do flexion, that tract takes to the brain. Okay, and then flexion of the joints and the tactile system is connected. Okay, whenever you need emotional stability, our body always goes into flexion. See the connection? Emotional development, tactile system, motor planning. When I am thrown challenged, when I am stressed, when I am emotionally challenged, we always go in flexion. After hard, long work, or if you are emotionally down, we feel like crying, we don't go lie down like this and cry. How do we go and lie down? We go in flexion and cry, right? So that's all direct link. I can talk neurophysiologically, but right now I'm not doing that. Okay. So sequencing, organization, visual perception. Like I told you, these are the skills that you develop through tactile system. Remember, tactile perception, motor planning, sequencing, organization, visual. Any activity, tactile system contributes. These are the functions of the vestibular system. Okay. Postural mechanism. You know, for postural control, there is something called central postural control mechanism, and that has a lot of very varying degrees of elements to it. Not discussing in detail. For that to develop, vestibular system is the contributor. Vestibular system, if it is functionally working and integrating well enough, it develops the anti-postural, anti-gravity postural muscles. My extensor tone in the body is developed by the vestibular system. Okay. If you want better extensor tone, you need to activate your vestibular system. Okay. Bilateral integration, skipping, jumping, playing tennis, playing cricket, all kind of bicycling, all these activities contributed by vestibular system. Okay. How? Okay. I'll give you one example. Vestibular system there's something called utricle, saccule, and semicircular canal, right? Okay. So utricle and saccule has its own function. Semicircular canal has its own function. When I move my body more linearly, it can be forward, backward, or sideways. Everything is linear movement. My utricle and saccule is getting activated if I do this. But when I do rotatory motion like this, my semicircular canal is activated. Okay. So remember, in this, if I have to do weight shift sideways, the weight shift side, my body has to elongate. Okay. So if my body has to elongate, that muscle, that side of the body of the muscle has to lengthen and elongate. That is contributed by the vestibular system. Okay. So that's why it has a major role in the postural mechanism development. Okay. So again, sequencing, visual processing, vision and vestibular system highly connected. Vision and proprioceptive system is highly connected. Vision and tactile system is highly connected. So that's why I said this integration of these sensory system has to happen if we have to be efficiently participating in all the functions that we do. Development of motor planning and motor skills. Okay? Vestibular system lays the foundation for. See, tactile system lays the foundation for emotional security when we are at the ground level. When we are moving in space, our emotions or our emotional stability is determined by the vestibular system. It gives safety in space. A sense of feel of safetiness comes from vestibular system when you are in movement, when you are in space, when you are moving, when you are moving against gravity. Okay? And vestibular system works closely with the proprioceptive sensory system. Okay? So proprioceptive sensory system is a moderator. Anybody who doesn't like, who is over responsive to vestibular system, and then you have been pushed into a roller coaster ride, how do you sit there? You start using proprioception in order to moderate the vestibular input that you are getting. You don't sit there like this. You tighten all your joints, muscles, right from head to toe. Why do you do that? So that you are moderating the vestibular input you are getting, so that you can feel safe. Okay, that's a key. Okay, so proprioception, like I said, it modulates both vestibular and tactile input. It kind of gives the alignment of the body. Again, it is interlinked. When your body is aligned, your vestibular system is switched on. You don't have to move at all. If you are even lying down, when you lie down, that's why some of the yoga asanas is there in lying down. But if you look closely, it talks about alignment. When you get your body in alignment, whichever position you are in, sitting, lying, standing, when your body is aligned, even if you don't move, your vestibular system is switched on. When your body goes out of alignment, for example, I am sitting, but I am sitting like this. Okay, that's out of alignment. Even if I move, my vestibular system is not on. Or even if it is on, it doesn't integrate well enough. Okay, so alignment is very key, and that alignment is provided by the proprioceptive system. Okay, so proprioception gives us better body image. It impacts our body position in space and time. So these are some of the functions. Okay, these functions I'm not talking. So these are the functions that is driving the skills that we require, that we are learning in this environment. Those are necessary. So now you kind of know why you need to integrate these three sensory input so that I can function better. Okay. Okay. So now you know what is SI. You know what are the sensory system it focuses on. What are the functions of the sensory systems? Roughly, you know, kind of. And I also talked about if there is a dysfunction, in what categories it is there. So it is there in two categories. One is sensory modulation disorder. One is sensory-based motor disorder. Modulation disorder has two types: over-responsivity, under-responsivity. You have both in tactile and vestibular. And sensory-based motor disorder, you have two types. Again, dyspraxia. When it is tactile, it is somatodyspraxia. When it is vestibular, it is postural disorder. So that's the kind of presentation that it will look at. So I'm not going to talk exclusively into assessment, because assessment is in itself is a big thing. Okay, usually in the clinic setting, assessment is a we have a lot of scales, but we don't use it on a daily basis. But general assessment is done through clinical observation model, meaning there is a set of activities that we do to make sure that we assess certain systems that we talked about: tactile, proprioception, and vestibular. Okay, I think there are 18 items in that. I can just list out some of them: are supine flexion, prone extension test, shoulder's arm extension test, forearm alternating movements, finger sequencing test. So like that, there are 18 tests are there. We do all that in clinic setting, and we also do free play, like meaning we let the child do whatever the child wants to do, and then look for the child's behavior in play, and then look for the sensory preferences and what the child's motor planning is like, child's ability to modulate certain information, all those things, plus the history from the parents. Like we also hear what are the child's history was like, and what the parents' concerns like, and their daily functional list assessment. So all those things drives our assessment. Then there is something called SIPT, Sensor Integration and Praxis Test, which is a golden standard for measuring sensor integration and praxis test, which we do not do on a clinical basis daily. It's mainly for research purpose because it's very expensive and it is a lot of time consuming. So those are the things that we use for assessment. But assessment is not like, okay, Wednesday is assessment day, you come in and assess and that's it. No, assessment is always ongoing, especially in pediatrics. There is no one assessment day. I would say every day is an assessment day, and every day is a treatment day. When it is, you work with the child. If it works, that's treatment. If it doesn't work, then it becomes assessment. So it's kind of like that. So you always go back, you hypothesize each behavior, and then you come back, and then you formulate the hypothesis, and then you relate to the sensory system, and then you do the clinical observation, and then there is always a correlation. There is 98.99% of correlation, clinical significance of correlation between clinical observation test and the sensory integration and praxis test. Okay, so right now, I think by next year we will have standardization of the clinical observation test. Once we have that, that means then we have an objective way of measuring even the clinical observation test. So that will be scored, and there is a pattern to do it. So all those things is coming up. That's a new thing in SI that's happening. As a PT, what I would suggest is like we have, when we work with children, when we see that they have problems related to muscle strength, motor coordination, balance disorders, postural disorders, we also need to think about the sensory system. We have the right to think about the sensory system because that is also contributing to those issues, especially in pediatrics. Okay, and then when you know the kid doesn't have a significant brain damage or noted some issues with the brain pathology, but still they have issues related to movement disorders, then it's important to look for the sensory system. And this is just a beginning. I said this is a very vast subject. This is not everything. I am just laid out the beginning. I mean, just a very small introduction that I've given, but there is plenty to it because each system itself will take one day to discuss. Okay, so this kind of an like overlook of what is sensory systems, what is SI, how it is categorized, and how you need to do assessment. As far as treatment is concerned, since we are not going into specifics of treatment, I will just lay out a general guidelines for treatment. So today I will just lay out only the general guidelines for treatment. Okay? First thing is prime most in treatment is, like I said, it cannot be so cognitive. Meaning, the child comes to me and then I say, you do this, you do this, you do this, you do this, or first this, second this activity, third this activity, fourth this activity. You cannot predetermine like that. And this is not a therapy, it's directed by therapist. SI is a very grossly misused, misunderstood word. Okay? Lot of people use sensory strategies. Sensory strategies is different from SI. Okay? When you say iris sensory integration is nothing but there is a definitive, there's something called fidelity measure that you have to follow in therapy. That therapy should meet these criteria. Then only it's called as SI therapy. Otherwise, you might use bits and pieces of information from here. That's not called as SI therapy. Clinically, in practice, most of the places, what it happens is most of the people use a lot of sensory strategies, but when they say it is sensory integration. That is wrongly understood, wrongly misinterpreted. I mean, it's grossly misinterpreted. So that's a sad thing. You just have to have certain principles that you have to strictly follow in treatment. That's what I'm going to lay out. The first thing is, it's not child directed. It's not therapist directed. It is child directed. Child is the boss. Therapist is not the boss. Okay? I cannot predetermine any activity. Second thing, your place should have specialized equipments. If it doesn't have, even though you are knowledgeable, you can use it, modify it. Still, you can do it bits and pieces, but you're not 100% complete. When I say specialized equipment, you need to have suspension equipments. Second thing. Third thing, just because you have suspension equipment doesn't mean that that's SI therapy. Okay? You need to provide enough opportunities for the child to experience all kind of sensory informations within that environment. That environment should provide tactile, vestibular, enough proprioception within that. You can also add in visual auditory. That's up to you. Minimum tactile, proprioception, and vestibular need to be provided within that environment. Okay, child should be an active participant. I cannot drag the child into the session. The child goes there and plays in corner and doesn't want to come in. I should be skillful enough to entice and teach the kid to come into and play with me or participate in whatever the things that we are doing. Said I go and pull this. No, I have 1 hour session with you. You have to do it because you are paying me. I have to do 10 activities with you. You cannot do that. And that's not SI. The child has to be an active participant. Okay? The fourth thing is, you have to challenge the child. We all know neuroplasticity cannot happen without a challenge. Okay? If an activity is too easy for the child, then that means there is no challenge in it. You have to challenge the child. At the same time, the child needs to have success. That's when neuroplasticity will happen. Challenge, success leads to neuroplasticity. Okay? Challenge and success leads to a lot of joy and fun. Challenge and success also leads to a lot of active participation from the child. Your activity that you design within your session needs to be focusing on these. Okay? And then the child needs to produce adaptive response. Adaptive response is a technical term that we use in SI frame of reference. It's nothing but an outcome. Everything needs to have an outcome. The child needs to be successful. So I'm going to tell you in short, 5 things that you remember. You need to provide a lot of sensory inputs. That means your environment should have a lot of sensation. It should have tactile, vestibular, proprioceptive input. So sensory environment, first thing. Second thing, intrinsic motivation. What is intrinsic motivation? Intrinsic motivation is nothing but I have an inbuilt want to do this, rather than somebody telling me, you go and do this. Okay? I know you people are sitting in front of the computer for 2 hours because somewhere down the line you had an inbuilt interest. Nobody forced you. If somebody forced you to sit here, maybe by half of the time you would have slept, or you would have left, or you didn't pay attention. You just on, but you don't pay attention to it at all. That means you don't learn anything at all, because without intrinsic motivation, we don't learn anything, even though I sit in front of this for entire time. Intrinsic motivation is the key. So the therapist's job is to tap this intrinsic motivation. You just have to keep looking for this. That's why this therapy is just not only science, it's also an art. You have to be like an artist to work with children. Okay. So the first thing is a lot of sensory input. Second thing is tap the intrinsic motivation. Third thing is active participation. The child should actively participate. Whatever you do, the child should be actively participating. Fourth is just right challenge. What is just right challenge? That's what I said. For neuroplasticity to happen, you have to give challenge at the same time. The child should meet the success. The child should feel the success. Okay. Without success, the child will not be keen to come back to you again tomorrow. Okay. So just right challenge. Fifth one is fun. Your therapy should look like the therapist and the child is having a lot of fun. The parent should feel, I am paying this therapist for nothing. If they feel like that, that means your therapy is successful. That doesn't mean that you take the child inside and you lock the door and then you don't do anything and have fun. That's not what I'm talking about. I am talking about your activities, your interactions with the child, and the child interacts with you. It should look like you both are playing. There is a lot of fun that's happening, as well as the challenge. Okay, so there is no forcefulness, there is no order, there is no dictator, there is no I am the boss, nothing. Okay, you just follow the child's lead and you be creative enough to create that adaptive response. And last one is that you need to be, every time you work with the child, you play with the child, you need to create an adaptive response. Adaptive response is a clinical integrator for us to know that sensory integration has happened at the subconscious level. Adaptive responses can be speech, in the form of speech, in the form of communication, in the form of motoric response, in the form of self-regulation, in the form of any academic learning. Okay. Output can be anything. It's based on what are the goal that you're setting and how you're setting and how you're going to do it. But you have to produce adaptive response. As a PT, I will always look for an adaptive response that challenges his motor ability, that challenges his postural ability. In OT, they would challenge on his ability to, work on some ADL skills and tolerate certain sensory inputs. Those are the OT. And as a speech therapist, they will look for maybe communication skills, ability to develop some language, sequencing of words, better articulatory ability, anything it can be. Okay, so the professional domains will determine what is these adaptive response is like. But whatever the profession we are and we are PTs, make sure that we produce that adaptive response. That's a clinical integrator of saying that sensory integration has happened in the subconscious. Okay, so I think I have passed my time enough, and I would stop with this, and then I will take up questions if you have. So these are the guiding principles in treatment. Back to you all.
Thank you so much, sir. We hope you all have a very good evening. The best and the beautiful things in the world cannot be seen or even touched. They must be felt by heart. Thank you is one such prayer among them. First of all, I would like to thank IAP Women's Cell Gujarat for giving me an opportunity to work as a state sub-coordinator and a central zone head Gujarat. It's a matter of honor for me. On behalf of KM Patel Institute of Physiotherapy, Karamsad, I would like to thank IAP Women's Cell National Head Dr. Ruchi Ma'am, President Executive Dr. Sanjeev Jha Sir, and IAP President Gujarat Dr. Dhara. I would like to extend a special thank to Dr. Bhavna ma'am, a state head IAP Women's Cell, for her constant encouragement and support. I am very grateful to our eminent speaker and to the one of the best pediatric therapists, Dr. Loganathan sir. In spite of his busy schedule, he shared all the valuable information regarding core part of pediatric, that is sensory integration. I am very much thankful to you, sir, from my bottom of heart. Very thank you, sir. We are enlightened with your presence and your knowledge which you shared today. I have learned a lot. I extend my big thanks to our enthusiastic participants across the India. Last but not the least, we are really very much owe to Almighty. Thanks to one and all, directly or indirectly involved in the success of this webinar. Thank you so much, sir. Thank you all.
Thank you. Thank you. I don't need to take any questions.
Yes, anyone is having any questions?
Anybody wants to ask any question, they can just unmute and ask the question.
Yeah, you can
I'm
even ask in chat box too.
Anyone has any questions, I'm happy to answer.
Sir,
You
it
just
was
have to
very
unmute yourself
excellent.
and ask the question.
It was excellent and informative, sir. It is continuously coming in the chat box.
Okay, I can see some of the questions are there, but I'm not sure whether they are there. Okay, so if nobody's asking, so it's fine.
Okay, thank you so much.
Okay,
Sir.
thank you, Shiva, thank you.
I would like all the participants to subscribe the YouTube channel of IAP for other such excellent webinars.
Yeah, ma'am.